And you mentioned about surgery, so I'm not sure who's best to answer this question, but why is surgery appropriate sometimes? So why would that be required?
I think surgery, John would be able to answer that in a better way, but I think in patients where the chemotherapy hasn't shrunk the tumor enough, or if the location of the tumor is such that it is affecting the renal function, then I think in those instances surgery would be a better way forward. And John can talk in more detail about the different aspects of surgery.
So is there anything about the surgery that as an initial sort of why somebody would decide to do that, or anything that you want to talk about?
So I think the thing to say is that, with regards to bladder cancer, we've made a lot of progress from recent research in understanding more about the disease and the way forward. And what Amar's talked about is using radiotherapy in combination with chemotherapy. But we do still know that there are certain types of bladder cancer that pathologically look different under the microscope and don't do so well with radiotherapy. So in those instances, your surgeon and your oncologist will always talk to you about that. There are certain tumours that are aggressive and don't respond well to chemotherapy, and in that situation you may go directly to having a procedure to remove your bladder. And then there are certain people who have medical conditions, which means they can't have either radiotherapy or chemotherapy, and for those patients cystectomy or removal of the bladder is the only option. Okay, and that's why it's so important that we work as a team to sort of identify which options are suitable for every individual patient.
Okay.
What is important to remember is that for the standard histology, which is the transitional cell carcinoma, for the majority of the muscle-invasive bladder cancers, either surgery or combination of radiotherapy and chemotherapy give equivalent outcomes. And in certain histologies where the patients don't do so well with chemotherapy, they don't respond well with chemotherapy, then we advocate surgery as an upfront option. But by and large, for majority of the bladder cancers, it is either surgery or the choice of organ preservation with a combination of radiotherapy and chemotherapy. They do have equal outcomes.
So we've heard a little bit about, in brief, about the surgery. So I was just going to ask, so Janet, how did you feel when you found out that you had to have a cystectomy?
Well, agreeing to have your bladder removed is a big deal emotionally. It might well be life-saving, and you know it's life-saving, but that it's equally life-changing, and that's quite difficult to get your head round, even though you know it's going to save your life. I needed sort of some time to get my head round that. I also was lucky. I had a lot of emotional support from my husband and family and friends as well, which I needed to sort of get myself in a place that I could accept what needed to happen. And I was particularly fearful of like my life beyond that surgery afterwards. I'm a relatively young, very active, sporty person. How was I going to go about normal life with a bag of urine on my stomach? How was I going to go running, go on walking holidays, go back to Pilates? What was I going to wear? All sorts of things about life, obviously looking forward. Having said that, about 18 months after my surgery, I must say that a lot of those fears are unfounded, and without a doubt you can carry on with normal life. But at the time, yes, it's a big deal. You know you have to have it because it's going to save your life, but you need some time and support to process the reality of what that means.
So now we're just going to go back a little bit more on the technical side. So John, could you tell us a bit about the surgery itself?
So radical cystectomy is a major procedure, and it's a procedure that we as surgeons take firstly very seriously, and it starts with the preparation for surgery. So we've talked a little bit about what it feels like to be given a bladder cancer diagnosis and a muscle-invasive bladder cancer diagnosis. We've talked a bit about the multidisciplinary team, And from the moment a decision is made that, yes, I want to have a cystectomy, there is a team in place that's involved in supporting you through that process. And that's the cancer nurse specialists, the stoma team, and Engler, who you're going to hear from later on, will talk a little bit about enhanced recovery also. From my point of view as a surgeon, making sure that you're fit for surgery is the next step. So patients will go to preoperative assessment and their fitness to undergo the procedure will be checked. And an anaesthetist may well evaluate patients routinely as part of their workup. And as long as patients are fit for surgery, then we proceed to doing the procedure. In terms of the procedure itself, a radical cystectomy means removing the bladder, but often we remove the organs that are close by also. So in a man, that's your prostate and your seminal vesicles. And in a woman, that's part of the vagina as well, because the vagina is adherent to the bladder wall as well at the back of the bladder. So from the operation perspective, that is what's removed. The bladder we talked about earlier was a storage vessel for urine, and the tubes are coming in from the kidneys called the ureters, which are draining all the bad products out of your body. So we need to find another way of diverting that urine to the outside world. So patients will hear the term urinary diversion, or stoma, or ileostomy, or even neobladder, and these are just different terms for how we bring the urine to the outside world when you don't have your bladder that you were born with.
Okay, and then I understand as well there's a difference with robotic surgery and is it open surgery? Is there any more you could explain about that?
So in terms of doing the procedure of removing the bladder and diverting the urine itself, in the main hasn't changed, but in terms of the method of doing the surgery, a robotic procedure is a keyhole procedure that we do to do the procedure. So that means that we use small cuts in the tummy, and we use 6 small cuts to be precise, and usually they're above the level of the belly button and then across the tummy wall. And then we use small instruments through those incisions to do the operation, and the robot holds the instruments and then we control the robot to do the surgery. An open operation involves making a cut below the belly button that goes down to just where your pubic bone is. So it's a small cut, and then we do the operation through that small cut.
You mentioned about the diversion and the stoma and the neobladder. So why do you decide what's the differences, and why do you decide to pick one over the other?
The decision about a diversion is a shared decision. So it's a decision that's dependent on the type of cancer that you have. It's dependent on the location of the cancer, and then also about your physical fitness as well and your motivation as a patient. So when we talk about a stoma or an ileal conduit, okay, that means on the right side of the tummy generally we bring a spout to the surface which urine drains through, and that spout's created out of the bowel. To do that is technically simpler. It involves less complications for the patient, and it also means that in terms of managing the urine drainage, it is very simple in terms of you just have to manage the bag and the drainage of the urine. When we talk about a neobladder, what we're trying to do is we're using bowel to recreate what your bladder was doing. So in essence, we're sewing up the bowel to make an artificial bladder that can hold urine for a period of time so that you can empty your bladder in a controlled fashion when you want to. That's a technically more challenging operation, so there is a slightly higher risk of side effects afterwards. And then in terms of looking after a neobladder, that involves a motivated patient. You need to be able to drain your bladder at regular intervals. You need to have the commitment, initially at least, to void by the clock. And you also need to be able to make sure the rest of your body health stays fit. Okay. There are a couple of other things that we check medically beforehand to make sure patients are suitable.
Okay. And the actual operation itself, how long is that?
Yeah, so I always say it takes as long as it takes to do it properly.
Okay.
But conventionally, I think that it's very important, just like we've talked earlier about robotic versus open techniques, the robot and open surgery are merely tools. It's very important. It's about your surgeon's experience and what they feel most comfortable with. And when you speak to your surgeon, they'll talk about what to expect afterwards as well. And it's usually our practice within our institution to call patients' relatives after the operation so they know that they've come out of the surgery and they're doing okay.
Okay. And then when they come out of the operation, is it expected that they go into ICU for a bit of recovery, or what happens after that?
So it is a big operation, and the majority of the operations that we do here in Bristol we do robotically. And for those patients, they may go to intensive care afterwards, but they're there very briefly. The practice across the country is different, and that's for the reason that what we want after surgery is for you to be closely monitored, so if something potentially did go wrong, it's picked up at an early stage. The advantage of intensive care is you do have one-on-one nursing, but in some hospitals they're able to provide that on the ward. Okay, so actually the location that you go back to is really only a marker of the importance of their attention to detail, rather than being the definitive place that everybody goes back to. Okay, does that make sense?
Yeah, thank you. So, Barry, I'd like to ask about sort of your experience. So, was your surgeon helpful in explaining?
Oh yes, extremely helpful. Gave me options. It was going to be robotic, and then he mentioned the cystectomy or the neobladder. I'd also done my research and said I didn't want the neobladder. So that was at that point he knew where we were going to go with it.
Okay. And how did you feel before your operation when you were sort of going in?
Surprisingly confident.
Okay.
Not worried. I had extreme confidence in the surgeon. Everything had been explained extremely well. I was probably on a bit of a high, and my wife tells me I sort of do things wrongly, and I was quite cheerful, no worries at all. And that was ordained to everything being explained, and to know what the possible outcomes would be. So, yeah.
You mentioned about stoma as well, so did you have any input into the position?
Yes, and I'd say that is very important, and I don't know if men feel the same, but particularly for a female to have or to work with the stoma team to identify the best position. I actually got marked originally when I went for the preoperative assessment. I got marked then for the stoma position, but when I went home and I thought about it and I thought of where it was with my, I like wearing jeans and things, I just felt that I needed it as slightly lower, so I actually contacted then my local stoma team at the local hospital. I went and saw them and had it repositioned.
And Barry, what was your operation like and your experience sort of afterwards?
As much as I can remember, it was fairly straightforward. After the operation, I spent just under a day in ICU, and then my total time in the hospital was 5 days. I was lucky enough to have a private room on my own, and therefore the treatments of the local stoma team came along. The surgeon came along just to say hello again, and it was quite uneventful, really. There was no complications. The 5 days went fairly quickly, and I was pleased with the outcome.
And did you, when they said, you're ready to go home, did you feel ready? Did you?
Oh yes,
yeah.
Yes, without a doubt. It was the right time. The amount of time I was in there was spot on.
And was your experience the same then, Janet, with your operation?
Well, I was actually in hospital for a full 7 days, actually, and I needed a blood transfusion afterwards. Just something that sometimes people happen. I needed 2 bags of that. So that's possibly why I was in 7 days, because the expectation would have been the 5 days and home then. It feels quite positive to get to the point that you're going home, but equally it's quite scary as well that, you know, you've got to manage this at home. But whilst you're in hospital, the stoma nurses were great and would come and help me every day to, you know, learn how to change the bag. I'm being someone that's incredibly squeamish and can't cope with anything like that, actually, because at one point I did actually pass out, I'm afraid, and the emergency buzzer had to go off. And even dealing with the stoma initially, I used to wear some of the gloves as well, because I just couldn't bear the whole concept of it. But yes, you know, you learn to get over all those things and manage that. So
you mentioned about the stoma nurses and stuff, so I assume that the stoma team played a part in all sort of your recoveries afterwards. Like, what was that experience like for you?
They were very good. They explained. I mean, if I can recall, there were some pipes coming out of it for some time. I didn't get independent from those until I went back to my local hospital, where the bag's fitment was done. But both teams here and at my local hospital were the kingpin to help your recovery and overcome this operation.
And what kind of advice were you given of like things that you should avoid doing? Was there anything that you were told to, oh, don't do this or don't eat that, and all that kind of?
It wasn't really anything. I mean, you're told to obviously drink water, you know, to keep your fluids up. That's good for you. And specifically around, well, to be honest, it's a major operation to recover from anyway. So, you know, you have to be, you can't really do that much. You really are quite inactive. Lifting, you definitely can't lift anything. So things I remember even asking a friend to move a vase of flowers for me across, because you just can't lift anything heavy like kettles and stuff like that. So
did you guys get any other advice or?
Just regarding the lifting and being mobile as much as possible to rest. So that was the order of the day, really, but it didn't last that long.
I was told it's keep it as active as possible, but listen to your body, rest when you think you need it. Obviously, don't drive until it's safe to do so. But literally, watch the lifting. Of course, being a typical man, I didn't, and within 12 months I had a hernia. So it's a man's thing.
So thank you to the patients for your perspectives on that. So hopefully video 3 has given you a better understanding of the treatment options available for muscle-invasive bladder cancer care. And in video 4, we're going to be looking at investigating living post-cystectomy and stoma care.